Let's start out with some mindfulness really quick.
No.
I'm going to lead us. And
doing this.
sorry, Alicia, just so you know, we've had
Welcome back to the show, guys.
some friction with mindfulness previously, but I'm really on an upward trend here. Okay, I'm just kidding. So welcome, Alicia. Our icebreaker question today is...
Do you want to tell people who Alicia is really quick, Preston?
So, hey, dear listener, Preston just got off nights. I have been up for 24 hours continuously, taking 2 hours naps for about 2 weeks now. So if I'm a little rough, that's why. This is Dr. Alicia Jeffrey-Thomas, who's a physical therapist and pelvic floor therapist, and she's here to talk to us about pelvic floor therapy. She's also the author of the book Power to the Pelvis, which is, from what I understand, basically a lens to view a lot of different health in your peritoneal area through the power of your pelvic floor. And as someone who doesn't have a pelvic floor and is pretty invested in all the women in my life,
Preston.
I'm really interested to learn about this.
I could not have cued that better.
Preston, you do have a pelvic floor.
Oh, no.
Everybody has a pelvic floor.
Oh my God.
It's literally on the first page.
I have read the entire book, and as contrast, he hasn't.
I started...
This is good. This will be very educational for you.
I was not enough pictures, and then
There's a lot of pictures, actually.
Well,
this is the most visual pelvic floor book you could get. It's
Can you... have you thought about including pop-ups? Or...
Ooh, that might be a little much for people. I don't know.
I don't think that we can put this on YouTube if I show the pictures, so I won't.
Right. You can show the nice exercise pictures, but
there's
maybe
a lot of photos.
not the anatomical images.
We're working on Preston's literacy skills. He's part of the male literacy crisis.
Yeah, hey, no psychiatrist left behind, am I right?
Okay, sorry, I'm being mean to Preston today.
That's fine.
We are kind of, our opening question is, I think a lot of times when we talk about this kind of stuff, as clinicians in clinic, we don't bring our personal kind of things into it. On this podcast, as Preston doesn't like that I say, I still have my own personal boundaries of talking about any topic. But one thing that I think a lot of people can relate to is having pain and going to PT. And so that's our kind of opening question for you, for me, for Preston, which is, have you ever been to physical therapy, and what was it like to actually go, or to go once and then not go again?
Yeah. So, I feel like I am in the minority because I think the majority of people that go to PT school get to the idea that they want to do that from their own personal experience. They, were an athlete and tore their ACL or did something to their shoulder and had to have PT. And I never did. I kind of accidentally fell into PT. My dad was having PT on his shoulder, right around the time that I was having to pick an undergrad major, and I didn't want to be exploratory. And I was going with him to his PT sessions, and I was like, yeah, this looks cool. This could work. And that was kind of my, okay, we're just going to set it and figure it out later. But I thought it was really cool how, this guy was, moving around the room so seamlessly, interacting with all these different patients and kind of keeping what was happening with all of them somehow organized in his head.
So your experience was being kind of there with your dad going through it as a process, but not necessarily for yourself.
Exactly.
Preston, have you been to PT?
Yeah, I have actually. And before I get into that, I'm still stuck on this. So can I do Kegels because I have a pelvic floor? Okay.
Can you? Yes. Should you? Maybe.
Okay. Wow. This is a lot. This is eye-opening. Okay, so I was a track athlete in college, and I got injured on my sophomore, junior year. I developed some kind of nerve strain through my back. I think my hamstrings were really tight, so they're kind of rotating my hips posteriorly. So all the ligaments and muscles on kind of my posterior chain were just getting stretched out a ton. So I went to PT, and one of the things they identified, in addition to kind of massage therapy and stretching, was that I had a sacroiliac ligament strain. So I got a ton of exercises to follow with that. I had this funky belt I had to wear to support me while I was running. And then I would do a lot of practice with plyometrics and jumping. And as much as I hated the belt and like I would get crap for it in the locker room and stuff because everyone else's PT was like cool, like
Hey,
an
belt
ankle
boy.
brace. And I was like,
And you get a Sorolla belt. Yeah.
I know. I was like, come on, man. And they're like, there goes Preston with his like big Captain America
There's a
belt.
belt boy.
I know. But it worked. So I was like, suck it, losers. This provides comfort to me.
You and all the
your
pregnant
insults
women that I work
fall
with.
off like water. So yeah, anyways, like I kept the belt. I would still use it anytime I kind of like ran into issues in the
You wear it when you're podcasting.
pelvic region, I guess. And then I would like put other people on it. Like, because it's like a pretty common injury, especially if you're running like 50 miles a week. You know, there's a lot of jarring that's going through kind of your pelvis. And if I think about it like a spring or a shock absorber, all those ligaments are getting a ton of strain for these like long distance runners. So I would kind of like put it on their differential when they're like, hey, my like hips kind of hurt when I'm running and like feels good when I'm rested, but like every time I go again. So anyways, I'm a big proponent of physical therapy, at least in the sense that like I've seen a lot of success with it. And I kind of understand it as maintenance that you need to incorporate into your routine rather than this like big fix all. And I think that's kind of where I see a lot of other people have misconceptions around it. But that's my overall positive experience with it. And my physical therapist was like pretty cool too. So
we tend to be.
So I've actually been following you for a couple of years because my experience with PT was in like med school / residency where intern year, we're rounding all the time and you're just like standing and leaning and just like you're changing positions, but it's just like there's no comfortable way to stand for like 7 hours while someone goes on about why the sodium is low or not low. And I'd noticed it sometimes in med school, and it was like kind of like lower back, like left side, like sacroiliac was what it eventually PT was like. This is kind of it. We need to work on your core and your glutes and also like your breathing. And I was like, okay, that's a lot of things. And then I was just confused because I was like, as a woman, I feel like there's so many cues in like exercise classes and just exercise classes in general that made me not like kind of disconnect more from my body rather than be more in tune with it. And once I was like, okay, my back is hurting. I can't run as much because the running makes it worse. Let me go to PT. And I went for like 7 months and it was like so different. I went like once a week for 7 months and it was so different than any type of movement I had before. And like to see myself even in like the little clamshells or bridges getting stronger was like, oh, I can get stronger and this does help. And I feel more connected to my body. And it really changed the way I like even just now work out that I'm not having pain. And I
Margaret takes creatine. Did she tell you?
Why would I tell her?
She like really works out.
I do work out, but I work out. I use the program Evlo. I don't know if you're familiar with Dr. Shannon Ritchie, who's also a physical therapist. But it really changed it. And I think I started following you then because I was like, okay, now my TikTok is like, do these 80 yoga poses and mobility things. And it's just overwhelming. And I'm like, I don't think I'm breathing correctly. But then how do you breathe? And all these things. Preston doesn't even have a pelvic floor. It's a whole thing. So I guess kind of coming into more of what we're hoping to talk with you today about is obviously your book, but also like the story of your work on TikTok. And I think that probably fed into you writing a book. I know in the intro you kind of say that. But that you've created a really unique platform. And you have, I think right now, like 1 million followers on TikTok. And it's clearly something that like people are drawn to what you're teaching. And your content is also mostly you teaching, I think. So when we come back from this little break, we're going to talk a little bit about Alicia's TikTok story. And then also, what is the pelvic floor? What do like primary care?
Pelvic floor?
Who has one? Should they be Kegling? And what kind of mental health and maybe general health practitioners should know about it in a couple different types of situations. So we will be right back.
And we're back to unlock the mysteries of the pelvic floor. But first, Alicia's story on TikTok. So, Alicia, I think we all have this initial story of like when we first posted, when we first went viral, kind of the second you started to gain traction and get attention on social media and kind of realize like, whoa, this is a thing I could do. So I'm curious, what was your motivation for starting posting? And then also, what was kind of your crux moment that you knew like this could be it?
Yeah. I originally wasn't posting on TikTok to like make it a platform. I was purely just using it to edit the videos and then just reposting them to an Instagram page that I was at the time co-running with somebody that I worked with. And so the original reason for making those posts was that we were trying to stay connected with our patients when they didn't necessarily feel comfortable coming in for treatments and things like that. And the Instagram page eventually fell to being just me. Basically, when the Urogyne that I was working with was able to go back into the OR, she was like, I don't have time for this anymore. So it became my platform. And then I had a video that just decided to go viral on TikTok. And I didn't know that it was happening because I wasn't looking at the app.
Because your editing app was just happening to show it to the audiences.
Exactly.
Okay.
And so I came back and I was like, oh, this has 300,000 likes on it. And
wow.
There were, it was nuts. It was the most innocuous video. I was just being my silly self while still trying to educate. Like it was some like just trending audio at the time. And all of a sudden there were people in my comments that were saying like, oh my gosh, I have had these issues for years. I didn't realize this could be pelvic floor related, or I thought this was normal. And so, I kind of like got myself into this state where I was like, oh, I have to respond to every single comment because these people are like feeling heard for the first time. And so I stayed up like all night responding to every single comment. It was not a good mental health moment for me, but I was like excited and like really wanted to kind of capture that and let these people know that, yes, there was information out there. There was help out there. They weren't alone, so.
That is so real. Like, the first time you get all of those comments, like all those notifications, it is like incomprehensibly overwhelming and also like intoxicating. And it's like energizing. I remember like same thing. I was like, I have to read every single one. I have to respond to all of them. Like all these people, like they can see me, like they're perceiving me. I try to picture how many people would fit in a stadium to be like, is this like what a stage would look like for that? So like 300,000 likes, you must have had like 3 million, some maybe more. That like
it was,
that's beyond anything I can picture. Like, perceiving it was like, you in a stadium,
right? I mean, anything. I'm sitting here thinking like I went to UF, and so our football stadium I think holds like 90,000 people. So I'm like, yeah, how many Florida Gator football stadiums of people liked that one post?
Yeah, and you go from like just editing videos to 17 Florida Gator stadiums, all with questions about the pelvic floor.
Right.
It's a lot. It's a lot really fast.
Gator stadium begging for information on why it hurts when they go to the bathroom.
What, the whole stadium's chanting, I thought this was normal before.
Am I Kegeling right now? Yeah.
All of us are Kegeling nonstop.
on the Megatron, like, you all have a pelvic floor.
What? So going from your stadiums, like what after that first night where you were rapidly responding to comments, how did did you just kind of keep making content that was sort of related, try to answer more questions? How did you go from then to kind of your now regular rhythm of posting?
Yeah, I mean, I think I started out trying to just like make videos responding to some of the more common questions that I was getting in those comments. Again, not thinking that it would turn into anything. I was just like, oh, well, like people want to know this information. I'm just going to like make these one-offs and then like go back to how it was before,
Yeah. You're just a vehicle for information.
Yeah. And again, like people just kept latching on to things. And so, I think because we were also in those like early pandemic stages of, everybody's just sitting around their house. I only have 1 or 2 patients a day. I have time on my hands. I just started making more and more content. And because I was able to follow the trends as they were happening, they were, continuing to get picked up by the algorithm. And so it just kind of snowballed from there.
So was there a moment that you started to realize, and I think this is true for a lot of creators too, that the audience was invested in you and not just the information that you were posting?
I think yes.
You seem like hesitant to agree with that. I just noticed, like, looking at your platform, like, there are a lot of people that look up to you, regardless of what you say, that they see you as an authority figure. And so that at some point, there's kind of that bridge between, like, oh, I'm just this physical therapist providing you with information, to, like, now I am Alicia, this fixture of the internet to be trusted.
Yeah. And I think it's when I started getting stories from other physical therapists who were saying, oh, hey, I had this person come in because they saw your videos and they mentioned you by name.
Wow.
You know, and that happened. I mean, people all over the country there. And then there started being people reaching out internationally. And it was just kind of this, like, you feel so much bigger than yourself, but so tiny at the same time. Like, oh, this is just me. This is just me sitting in my little, closet office and making videos.
Telling them to go piss, girl.
Yeah.
Yeah. And changing the world.
Yeah. One pelvic floor at a time.
One Florida Gator stadium.
One Florida Gator. One confused Gator stadium. I think this, one of the things I want to make sure that we get to talk about today is kind of this, I think that there's a lot of overlap, and I will say I work in perinatal and eating disorders. And so the mind body is big there, and then pelvic floor, obviously, pain, what's going on with the pelvic floor, like pre-pregnancy, pregnant, postpartum, post-loss, anything, and how many changes are happening. And there's a chapter in the book where you do talk about kind of pregnancy, but I'm wondering, I guess, if there's one thing that you feel like is the biggest misconception, or the misconception that pisses you off the most, either one. What would you start with? And then we'll talk a little bit about the mental health overlap. But I think some basics are probably necessary at this point.
Yeah, I was going to say, from a really basic standpoint, I think the two, well, I guess the number one thing being that, like the pelvic floor is just Kegels. That's all pelvic floor therapy is. And, kind of saying, you can just do this on your own, just do Kegels. When a lot of times, especially if we're dealing with people who have pain or, have no idea how to even start to coordinate their pelvic floor, you're not setting them up for success. They're going to get frustrated, or their symptoms are going to get worse. And then they're going to be like, oh, well, this doesn't help me. Let me move on to the next thing. And they've only explored like 3% of what we could possibly do for them.
So managing expectations about, like, what the pelvic floor is capable of.
Right.
Or what change is possible through the pelvic floor.
Yeah. I mean, because, when you see pelvic floor content online, you're going to see my content sometimes, but a lot of the times the things that go viral are those Kegel to the beat challenges.
That is not on my For You page.
Okay, well,
you're blessed.
It's usually some Australian woman, and
you
she's
don't
like,
have a
all
pelvic
right, we're
floor.
going to squeeze our pelvic floors.
That's about to be my For You
bullshit. There's so much bullshit. It's because I feel like pelvic floor, like, therapy has gotten caught up in the, like, wellnessification of, like, legitimate, like, there should be more access to care. There should be more conversations with less stigma around these parts of women's health. But then it gets, like, caught up into, like, I'm a pelvic floor yoga teacher and everyone should be doing these 8 stretches. And it's like, maybe those are good stretches, but...
Or, like, I'm a Pilates teacher and I've just decided to brand myself as, like, the pelvic floor Pilates person.
Yeah. Which, like, again, if you have training to be able to speak about these things, great. But a lot of times, like, that training is limited to how, to cue somebody maybe correctly to activate their pelvic floor when they're doing an exercise. But it's not thinking about, how it connects to movement, how it connects to breathing, pressure management strategies, all of the things that we're going to be thinking about in therapy, especially in, like, a group fitness setting. That's really tough.
Yeah. So I guess, interestingly, the only way I've come across the pelvic floor and throughout, like, studying in medical school and on tests has been incontinence. So, like, rather than, like, hey, here's a way to become healthy and a way to, like, coordinate your movement, and then, like, pelvic floor, it's been, if someone's incontinent, what type of incontinence is it? And then, like, pelvic floor issues might be on your differential for them. So I think, like, I feel like throughout my studying, I was kind of just trained to associate pelvic floor with incontinence. And then I never really thought about it in any other context, which is why I didn't even know I had one.
Right.
I was like, I'm not incontinent.
Right.
No pelvic floor.
Right. And it's, I mean, even when I was first introduced to the idea of pelvic floor therapists, it was through the very narrow scope of pregnancy and postpartum, incontinence, and sometimes pain was mentioned, and so it took me getting into the field to realize, oh, it's so much more than this. It's people who have never had children who have, excruciating pain from endometriosis, or it's, men post prostatectomy who are having urinary incontinence, or it's, people kind of all through the spectrum of life and circumstances. Like, it can follow you no matter what's going on.
One of the things I liked in your book that I feel like helped me kind of understand more broadly the pelvic floor was like, I think you have like the 4 functions, or the 4 kind of
the
ways.
4 S's. Yeah.
Yeah. Can you talk about those? I thought it was so helpful.
Sure. So basically you have your sphincteric functions, right? So for bowel and bladder control, opening and closing, to allow those things to happen. You have your
valve functions.
Yes. You have your supportive functions, right? So holding up your internal organs, helping to, prevent pelvic organ prolapse and things like that. You have your stabilization, I guess, function. So it's working with your core, it's working with your diaphragm, it's kind of helping to stabilize your spine and things like that. And then there's also the sexual function aspect, where the superficial aspects of the superficial layers of the pelvic floor are involved in orgasm function for everyone.
Yeah, so it doesn't.
Men have pelvic floors too.
There's a plexus, like a nerve plexus, that runs through the pelvic floor, right?
Mm-hmm. Mm-hmm. Yeah. The pudendal nerve is the big one that everybody.
Yeah, and that one can be connected to the clitoris or other
the superficial functions. Or the superior portion of the pudendal nerve goes to the clitoris, or the dorsal nerve to the penis.
Gotcha. So is that so? This may be an off-topic question, but I think it's germane.
Where is the topic?
You know how there's exercise-induced orgasms, where women will be lifting or squatting or something in the gym, and that can induce an orgasm. Is that through the sexual function of the pelvic floor?
Yeah, I mean, basically, you've got this activity of the core, combining with activation of the pelvic floor, and for some people that can trigger an orgasm.
I guess a question I have related to this, if we go from kind of basics into what you see, I guess I'm curious just overall from what you think the connection is, or what you see most commonly when you're thinking about how mental health is impacting the patients you see and how pelvic floor therapy goes for them.
Yeah. Because I mean, if you think about it, this is an aspect of the body that is still considered in a lot of circles to be taboo to talk about. And so pelvic floor symptoms, pelvic floor dysfunction can be very, very isolating. And that can have a huge impact on mental health, whether it's you don't feel like you can talk about the issues with your friends, or you start to limit the activities that you're doing. You don't work out the way that you used to because you're afraid that you're going to leak. There's tons of ways that this can show up. And so the people that I tend to collaborate with the most as a pelvic floor therapist are going to be my mental health professionals, because there's a lot that I can talk to them about from the lens that I'm working with them in. But I think having that collaborative care is really, really important, because we don't want to discount, how a chronic pelvic floor condition can impact your mental health over time.
Mm-hmm. Yeah.
So I was working with a benign gyne who did a lot of pelvic floor interventions in medical school. And it was interesting because, like you said, it is taboo to talk about the pelvic floor, and it's also taboo to talk about your trauma and your depression. So there were a lot of patients that were coming in with the chief complaint of dyspareunia, and she would give them numbing or relaxing injections in their pelvic floor pretty routinely. But then she was telling me I've become a lot more invested in applications of psychiatry here, because a lot of these people's main complaint is their trauma and their stressful interpersonal relationships with sex, with their partners and other things. And then the only thing that's coming to the surface now is this pelvic floor sexual dysfunction.
Mm-hmm.
Yeah.
Yeah. No, absolutely. I mean, I think there's a really important role to be played in using those types of interventions, but we want to get to the root really of why this is happening. You can slap a Band-Aid on it temporarily to maybe help you to make some progress, if you're reducing that pain level, but we want to know, why that anticipatory contraction of the pelvic floor is happening if you go to try to, insert a tampon or, have sex. And so, yeah, I think that's really important to have that together.
I think one of the things, so I put up a poll on Instagram and ask, before our episodes, ask for questions people have, and we'll get to some of them. But one of the things that came up a number of times, and I think is also part of like the discourse on TikTok and sometimes clinically, is this idea of like trauma being stuck in the hips or pelvis. This is I think it's a subject we have to be really tender and careful with. But I wonder what you think when you see that online, and also if patients ask you that, and how you kind of help them understand what we know or what we don't know.
Yeah. Again, I think in certain circumstances, I try to meet the patient where they're at. Because I have certainly seen people who, when we're doing deep like abdominal therapy, like a psoas release or something, they'll have that very emotional moment where they'll, break down and start crying. Mm-hmm. And so, I'm not necessarily going to go like on the full spectrum of like, oh yeah, there's trauma stored in the hips, but like your body does respond to, certain stimuli. And sometimes that can be a really emotional process for people.
Yeah.
So if someone, let's say you've identified they share their trauma in the hips, or like this is a place where their trauma is presenting, how do you start to approach kind of therapizing that or releasing that?
So I like to give them the like ownership over it. So yes, I'll do hands-on manual therapy with people, but also if I can give them an exercise that helps them to, feel the same thing, so that they feel like they can, go home and have this control over this one piece, then I'm going to aim to do that more than having them rely on me.
So can you give me an example, just so I can like better understand, like, let's say my issue is incontinence and there's like some exercise you've identified. What would that kind of like look like with you giving ownership or control to the patient and kind of your follow-up relationship be?
Sure. So if the way that it again kind of depends on what's going on, but like
Sure.
A lot of times I'll see people who have incontinence, not because necessarily their pelvic floor is weak, but because they're maybe like doing weird guarding patterns elsewhere in their body. So they're clenching their abs all the time. They're always sucking it in. And so giving them, the ability to kind of almost kind of do like a body scan of like, okay, like, am I clenching my abs right now? What can I do to try to relax that? Is that a breathing exercise? Is that some kind of cobra stretch? Is that kind of, some kind of hands-on thing where I'm scooping my belly and trying to kind of like allow it to relax underneath the feel of my hands? There's different ways that we can go about it depending on what's happening with that person and what they're going to respond best to.
Okay. So the exercise of movement is not just activation, but almost like deactivation, really just helping them to like listen intently and I guess non-judgmentally to how their body's reacting to things. That's a theme that Margaret and I have, is non-judgmental listening.
Mindfully.
Margaret needs to practice that when I talk, but I'm pretty good at it.
So needs to know what mindfulness is. I think an example that people bring up, and maybe the example you gave, Preston, I think the one a lot of people think about is if they have a trauma history and there is, especially if there's any trauma that's related to bodily autonomy, that maybe they know that they should go see a pelvic floor therapist, but they're scared about what it'll be like beyond just maybe this is a different type of thing. I don't know what to expect. There's taboo, but kind of maybe they've been traumatized before by like a pelvic exam for like getting a pap smear or something like that. And I wonder if you had a patient coming in who was this person that is like, I'm nervous to come in. I'm not, there's nothing particular about like physical sensations that is necessarily related to this. This has been present, or I'm postpartum, whatever. Like, let's say that there's pain. How might you think about your first visit with them, or how you talk to them and give them more autonomy or choice in this kind of very different and maybe feared situation for them so they can access pelvic floor therapy?
Yeah. So I always start out my description of, how day one kind of tends to go is you're in the driver's seat. You get to decide how much or how little we do. There are people whose first visit to pelvic floor therapy, all we do is talk. and we get to know what's happening with their symptoms and really kind of dive deep there. And maybe I walk them through, using like a plastic 3D model, like what that exam would look like. And we say, okay, like we're not going to do this today. We can think about how we might like to approach that in the future. Because like my exam, there's no stirrups, there's no speculum, there's no like inherent scary stuff. But at the same time, the idea of doing an internal vaginal or rectal exam, depending on your anatomy, can be really intimidating for people. And so we can say, okay, we can start out and do this kind of in layers. We can do just an external observation. We can do external palpation if you're comfortable with that. Or we could do internal. And at the same time, at each one of those stages, you're always allowed to say no. You're always allowed to stop the exam. There's no point where I'm going to be like, well, no, we need to get through this. It's all about gathering we want to gather the information that we can to help to support you getting better, but that doesn't have to happen on any kind of specific timeline. I would much rather keep your nervous system in a calmer place so that you can have that improvement.
I think it's so helpful in your content you make that you show what an approach like this can look like. Because I think a lot of people can't imagine what pelvic floor therapy, physical therapy is like. And so I feel like one of the things in your content is that it's like you're telling people they're going to have choice. You're showing what's like, that it's okay to need this service. And it's also okay to take your time and have some creativity in how it is going to go. Because I think about a lot of my like highly anxious or patients who do have a lot of trauma, that this is mostly my clinical experience where it's like postpartum, let's say that they're experiencing pain 12 weeks after birth or they're experiencing like incontinence. And then if they have anxiety or if they have a lot of self-judgment anyway, that makes them even more anxious. And then they become on high alert for kind of body sensation, and it can kind of create this loop. And so I feel like just seeing in like a normalized way, even on TikTok, like this exists and it's okay and we're fun and like we can be silly about it is so important when it's such a taboo topic for a lot of people that they feel a lot of shame around.
Yeah, no, definitely. It's you. Nobody likes going to these types of appointments, right? And so I feel like as a profession, pelvic PTs have kind of realized that. And I feel like we're all kind of fun people. Like we understand the inherent weirdness. And also I think a lot of this comes from how we're taught. So I don't know if you know this, but like when you're learning how to like do an internal exam, the standard in the PT world is that you learn like on each other.
That's how it used to be in med school.
Yes. So like, I understand the inherent weirdness of having to like get half naked and get this exam from some person that you've never met. However, mine was also in a room with 40 other people at the same time. So that's usually a good icebreaker with people.
It really quick.
Yep.
Have you had any counseling training or like ways to approach these emotionally? It sounds like you have a great process, and I'm wondering, did you have to figure this out on your own?
They really try to build it into the coursework that you take. I also was really lucky in that I got to do, clinical rotations with pelvic floor therapists. So I got to see how they addressed these situations in real time as they came up. Yes and no. I think we could do a better job. And I think that I'm personally always kind of seeking out more trauma-informed approaches. I have a friend who's a PT who does training on trauma-informed care for pelvic floor therapists. So like resources like that are starting to jump up.
It's fascinating to me. Like both physical therapists and mental therapists like apply the practice of therapy. And I think what almost came to mind is that you're a nervous system therapist as well as like a muscular therapist. And so part of your role in improving the health of this like region of the body is to like calm the nervous system. So that means having this very effective approach, regardless of like being another human who's like empathetic to someone. I was struck by your point. Like I want their nervous system to be calm during the exam because otherwise like all of this is kind of fruitless.
Speaking of like calm, we had a question, not we actually, Preston had this question and our producer had this question, which is about kind of calming your nervous system, but it's about breathing. And I think in the book we said breathing into your butt.
Yes.
So after our break, we will come back and talk about that, as well as some of the listener submitted questions. So we will be right back.
And we're back with butt breathing.
Yeah.
So before we get into any of like the assumptions or preconceived notions I have, can you just describe to me what you mean by breathing through your butt?
Yes. So it's a cue that I use to get people to connect with their pelvic floor while they're breathing. Because a lot of times when we're breathing, we're keeping it very shallow, kind of chest breathing.
Mm-hmm.
And you can do a lot with connecting to your pelvic floor in terms of relaxation if we're kind of cueing for that like full expansive breathing into your butt. I want you to feel like, hold on, pelvis incoming, right?
Oh, yeah.
Okay.
All right. So your pelvic floor is kind of sitting at the bottom here like a hammock, right? So when you breathe in, this is your diaphragm. Your diaphragm is dropping down. Your pelvic floor is going to move in the same direction. So if you imagine kind of like literally breathing in, not literally, but like imagining that air going down into your butt and expanding that tissue down into the chair that you're in. Yes.
Okay, give me a second.
Okay. Yeah, you might need to practice. It's not intuitive for a lot of people.
I think I have a lot of anticipatory contraction.
Yeah, probably. So sometimes what I'll do is I'll give people the cue to do this in like a child's pose with a pillow kind of up underneath them so that it's like resting on their pelvic floor, or their pelvic floor is resting on it. And you can feel in that more relaxed position then when you inhale, almost your ischial tuberosities, your sits bones kind of expanding, your pelvic floor kind of dropping down into the pillow a little bit.
Okay. Rather than just pushing to the office chair that I'm sitting on now.
You're not pushing. You're just riding the elevator down.
Okay.
I'm going to just comment on your next TikTok, Preston, when you're doing push-ups and be like, you're not breathing. Preston.
So here and then.
Yeah.
I don't know.
Wait, put it. No. Up under your butt. Under your butt.
Preston.
Do you?
Wait, sorry.
You got a copy of the book, right?
He has it. Yeah, he has the
Okay, I'm like going to look up the page.
I'm a visual learner, but
God,
but it's always good to practice it yourself.
Right. No, for sure. Hold on. I can't remember if it's 43 or 102, but it's one of them. Okay, it's page 43.
They make me do child's pose and Pilates sometimes.
Yeah. So like
under your butt.
Oh,
under
I can see
your
it.
butt.
You
okay.
can feel.
Okay. Gotcha. Stand by.
We can put this behind a paywall, I think. If I knew, I made a joke 2 months into filming, 3 months before the push-up challenge. I was like, well, yeah, Preston, what are you going to do for your like New Year's resolution? And I was like, you're going to do a bunch of push-ups in front of people. And then he just started doing it. Preston.
on the chair is the...
He's going to break his skull.
Preston, your pelvic floor is not going to relax.
You're not going to relax that way,
Preston. Did you feel it?
Well, I think I felt the floor go down a little bit.
Yeah.
I mean, that was kind of awkward because I was like bouncing on a chair.
You think?
But much different than sitting upright.
Yes. So that's the thing, is if you can't feel it in one position, try it in another position.
You're learning so much today, Preston. You could have used
this is cool.
These techniques on nights when you were
No, I feel like I literally just discovered this, 40 minutes ago that I even had this thing, and now I get to use it.
And you're the first man to ever discover it.
Yeah, he's Christopher Columbus, the pelvic floor.
You and Kegel.
Oh man, more men need to know about this. I'm gonna start to raise awareness.
That is actually true. That is actually true.
Well, but we'll just do it with like I don't know, like on Ice Road Truckers commercials or something. Yeah, they like advertise for ED.
I can't wait till like 2 episodes from now and
you
you're
have
like,
trouble pissing, man. You need to think about your pelvic floor.
I can't wait till like 2 episodes from now and you're like, Yeah, Margaret, I don't know if you know about this, but there's something called the pelvic floor, and I wonder if you've thought about it. Um, is why do we get taught to breathe differently? Like, why is every exercise class like suck in and do this? Which I feel like a lot of my PT was just being like, she had me do one thing that was like put a weight like a light kettlebell on my stomach to feel like what is bracing and not just like bearing down or pushing out, but like bracing, and then also then practicing the breathing at the end of noticing like the cues you were saying. And I was pissed because I was like, why am I told only wrong things about like this?
I think a lot of it was honestly like the, 2000s heroin chic diet culture where we're just like, we need to be as small as possible. So we're constant skinny. So we're just constantly sucking it in. And then we don't know how to breathe other than to just like be really shallow with it.
I was like, this is like the bullshit of this where it's like, okay, you need to be skinny to be attractive so that you can have kids. It's biologic, like that rhetoric. And then it's like, what if, and then we're going to make you less actually able to.
Right. We're going to like jack up your pelvic floor in the process.
And we're going to make, it's like, how can it be both? And it cannot. Do you want to talk about how people shouldn't be going to the bathroom 100 times? Because I feel like that is something I learned from you. I actually didn't need that advice, but I was like, interesting. Are that many people like going to the bathroom just preemptively?
Oh yeah. So you're specifically talking about like the just in case peeing, right?
Yes. I think that is what I've seen.
Well, because I think we all saw that one, ER physician who was like, you could rupture your bladder if you're, in a car accident and you have any pee in your bladder. So, okay, now everyone is just peeing 8 times before they leave the house. But basically, okay, so your bladder is like a balloon, right? So it needs to be able to like get used to expanding to a certain amount, and then it just kind of like deflates to help to push the urine out. Your pelvic floor just needs to relax and get out of the way. If you're not letting that balloon fill up regularly enough, then it kind of loses some of that ability to like do what it needs to do. And it tricks your brain into thinking you actually have to go more often than you do. You feel like, oh, I have this small bladder capacity. Really, no, you've just kind of like messed with your brain's interpretation of when your bladder is full.
That's so interesting.
I had no idea. Like the detrusor muscle in your bladder stretches, right? And that is like kind of what gives you the signal that you have that urge to pee. So I guess what you're saying is if I never let my detrusor muscle expand, it's going to stay tight. So even when it's really small, that little bit of pressure is going to be enough to make me think, oh, I'm full.
I got to go piss, girl. That's
exactly.
Kind of like when you, like if you fast for a long time, your stomach starts to shrink so you feel full easily.
Right.
Afterwards. Okay. Did I do good, Margaret?
You did so good. You did so good. You did so good, baby girl. Okay, I want to make sure we get to the questions because people had a lot of questions about this on Instagram. So one of the things that I think I would love to know your experience with this, Alicia, and then maybe Preston and I can also answer a little bit on this. One question was, can anxiety meds be used to relieve pelvic floor tension?
So I have certainly seen people who had anxiety or have anxiety and were unmedicated. And when they started taking medication, once they kind of got things, right after all of the experimentation there, then it definitely affected their pelvic floor. I see people who are just those kind of chronic tense, clenchy type people that like, when we can offload some part of the nervous system, it just kind of cascades down, which can include their pelvic floor.
One of the things I noticed when I was a second year and going to PT was like when I was on nights and more stressed, that I would notice my like back pain more. And so I feel like what you're saying of like, can pelvic floor pain or ability to even engage in pelvic PT be impacted by it? That it's like, one of the main things we ask about with like generalized anxiety disorder, one of the core symptoms is like, do you hold tension in your jaw and your shoulders? And like you are always breathing shallowly and you're feeling like your chest is tight, which clearly from what you're saying, there can be a connection between all those things.
So One thing I noticed too that people get frustrated a lot with online is like I had these physical problems and then they told me it was just anxiety.
Mm-hmm.
They told me it's all just like related to anxiety. But in a lot of cases, I mean, I don't like to discount anxiety to say like, well, it's not just anxiety. Like anxiety causes a lot of these things. But if you have that suspicion, I guess someone's coming in for pelvic floor therapy, they're very fixated on it being somatic
Mhm.
and through their pelvic floor. How do you kind of introduce the idea of like, hey, maybe this is anxiety without coming across invalidating? Because I think a lot of people have resistance to that.
Yeah. I mean, I think from the jump, I'm always talking about how the pelvic floor, integrates with the nervous system. Like when I teach people how to like breathe to relax their pelvic floor, and I'm like, and we get that other benefit of kind of addressing any fight or flight, tension, anxiety, whatever that's building up. So it's always kind of in that conversation. It's never, oh, well, we have to introduce the potential that this is anxiety. Like,
Let me sit you down.
Yeah, I feel like I'm like, we all kind of know, right? Your pelvic floor is tense, your jaw is tense. Like there's something else going on more broadly than just this is a clench thing that's just happening on its own. So we have to figure out where that driver is.
Yeah, so it's like you start with the pelvic floor and you almost kind of walk them back to anxiety, maybe using different words like this is a fight or flight. The nervous system is very involved.
Yeah.
Almost like they can kind of come to the idea themselves like, hey, do you think my anxiety might be related to this? Whereas I think some people, even if like you and I know that anxiety is probably related, they'll jump to be like, oh, this is probably related to anxiety. And even just like saying that off the jump, while it may be like relevant to the patient, I think can be invalidating.
Yes, because I mean, especially now, right? Because it's like almost become a little bit of like a triggering word for people. You
like
have
a platitude to drop on a patient.
Right. Right. And especially your female patients, especially your patients in pain who, because there's also, the evidence that says that there's a lot of women who come in for pelvic pain, 1 in 10 are going to have endometriosis. And then you're just telling them that it's anxiety,
Knock
and
it
so,
off.
Yeah.
Stop. Yeah. I think that I worked with a pain psychologist my 4th year in med school. And one of the things she used to say is like, so if someone was like, are you saying this is anxiety or this is all in my head? And she would kind of say, well, if I cut your arm off, it would hurt because it's all in your head. So like we're just talking about all your neurons, and your neurons are sending signals of pain.
Yep.
And I think it also is helpful that it's like in pain conditions where something's wrong versus ones where people are and have been dismissed in the medical system is like, there's nothing wrong with you, get over it, and aren't given support.
If you're experiencing pain, something is wrong, period.
You're experiencing pain and you deserve support. I don't know that I would say something's wrong. But
well, no, because when I'm saying something's wrong, it doesn't mean there's like a somatic issue somewhere, but like you're experiencing disorder, therefore something is wrong.
Something's misfiring.
Yeah, there's a problem. Yeah. Is I guess my point in saying that.
Yeah. But she would say like, anytime you're experiencing pain, it's a neuron thing, and I care about your brain and your neurons throughout your body.
Yeah.
And I feel like her being like, well, that would also be your brain base if it was cut off. But yeah, I definitely think it's a mixed issue. I think in the book you mentioned, right, that, that there's these expectations that I think women are given often of like, sometimes just like having sex is painful, like have a glass of wine, or, well, once you better get used to like your body being different after birth because you're just going to be peeing your pants all the time and that's it, or you're always going to feel XYZ way. And it's paired with the body culture of like instant transformation, get your body back or whatever. There was that like getting your pink back, like flamingos that was happening 6 months ago. Apparently, like after birth, Preston, like flamingos like become more like less pigmented or something during pregnancy and birth, and then they get the pink coloring back. And it was a whole thing. You're lucky that this is not on your For You page.
Is that right underneath the like, Australian Kegel?
Yes.
Beatboxing or something?
It's in the same scroll sesh.
Okay.
And then there's like a discourse about it and like how like that person's but like how do you when patients bring those up, and obviously you educate, but I guess I wonder if you could address those couple things, that it's like pain with sex is just something that's going to happen, and then just like once you've had a baby, this is just like your body now, and like how you address those misconceptions.
Yeah. I like to tell people that, just because something is common doesn't mean that it's normal, doesn't mean that it's optimal, doesn't mean that it has to be your forever, right? And so, there are plenty of people, you can point to plenty of people who have had a kid and don't pee their pants. So therefore it's not what, should just be expected for everyone.
Like my dad, he had a kid, he doesn't pee his pants.
The dads, exactly.
Yeah,
the dads can do it. Why can't the moms?
No one talks about the dads.
They suffer in silence,
They're not very silent.
And then like with the, the painless sex stuff is just, it's so layered, right? Because there's so much of it that's what kind of messaging did you get before you ever had sex for the first time, about your body and what, what to expect those, that first time, even, if you've had a trauma history, any of those things. And even in the absence of that stuff, you can still have people. I had a patient once who it was almost this like weird, inexplicable thing where it's like, I don't have trauma. I don't have any of these bad messaging. I really want to have sex. I don't understand why this is happening, And so, it's a matter of working through the why for that person, but then also just letting them feel supported and letting them know that getting out on the other end with that positive outcome is possible.
Yeah.
And then, kind of to what you were saying of the bouncing back and all of that stuff. I talk a lot about pelvic PT in terms of regular PT. So when we talk about how long it takes for, muscle hypertrophy to happen, it's like, okay, well, you can't do Kegels for a week and expect this to happen, because even if you're starting a new strength training program in the gym, the first 6 to 8 weeks is just dusting off the cobwebs and being like, all right, body, this is how it's supposed to go.
Preston's day of the year Kegel challenge instead of push-off. Sorry. I'm sorry. That was an intrusive thought.
I'm in Kegel debt. As bad as I'm in push-up debt.
Just you standing in front of the camera,
Kegels behind,
not moving.
It's just me talking, and then I'm like, oh, by the way, we knocked out 50 Kegels
right
in that
now.
session.
But the bouncing back, you're saying you wouldn't expect muscle to be built after a week in the gym of just doing an exercise.
Right. So you can't expect that your, pelvic floor symptoms are going to respond that quickly either. And then especially, you're kind of starting from behind once you've, gone through 9 months of having a pregnancy, right? And going through, whether you have a vaginal delivery or a C-section, that's a big event. Think about it like having, some kind of a C-section is major surgery, right. How quickly do you expect somebody to bounce back from a major surgery while caring for a newborn?
All women should bounce back immediately. You are bad. I'm just kidding.
The messaging for recovery in women is so toxic. Just listening to how you guys have to navigate that. I'm trying to picture a guy who got a prostatectomy or a TERP or something being like, how to get your load back, You know what I mean?
Yes.
Come on, man. Is your load not the same after you had your prostate cord like an apple? Here's how you blow your load like you used to. We're just like, no, blame your wife. she can't get you off. That's your problem.
Oh my gosh.
Okay. I'm going to ask one of these other questions because I don't know where to go from there.
Ice road truckers, are you having problems with your load?
Dude, your Kegels.
On and off the road.
We're going to call it the Melvic floor. It's the man pelvic floor.
I remember the first time that my husband and his friend figured out that men have pelvic floors, and they were like, so can we do Kegels? Can we do butt Kegels? And I was and so they started calling them I forget who started which way, but I think they were calling them bagels. And I was like, no, it's actually pronounced beagles. We had this whole back and forth about butt Kegels. So.
Meagles.
Yeah.
Bagels. And Kegels.
Gotta add that in there.
Omegle.
What?
Sorry, this is not helpful. Derailing the conversation.
Post nights. This is maybe not. I think this is both the worst and the best episode for us to do in Preston's post nights and just like free associating.
Margaret, please get back to the question.
I'm going back
I
to
need
the
structure.
He's gonna be like trying to Kegel again over on the chair. One of the questions was someone had talked about, I guess this would be a question for us as well, but like SSRIs, sexual function trade-off. I wonder if you ever see that or have people talk about like that with you in your line of work. Like, I'm a lot less anxious now because I got a med from my doctor, but now I feel less motivated to do this. Maybe like the desire for sex is less there. Right? Like they're doing this kind of difficult, worthwhile work in PT, but then we help and maybe we hurt by decreasing the drive for sex and decreasing ability to orgasm.
Right. It's, and I also, there's also the use of SSRIs in like certain types of pelvic pain, right? So we see this come up in a lot of different ways. And I really don't know that I have an answer for people. It's really just kind of being that support and saying like, okay, like, here are the things that we can control and that we can affect, given that like for all of the reasons that you just said, like we probably want to stay on these medications.
Yeah, I when I talk about sexual dysfunction, I guess mostly from the guy's side, because I'm just reflecting how I interact with patients. I'm a lot more comfortable talking to like other men about like sexual dysfunction they experience in SSRIs, whereas like for women, I'll be like, it might be harder to orgasm. And then that's usually where our conversation ends. But I try to kind of describe it as almost like guardrails where I'm like, because a lot of guys have concern about premature ejaculation too. So I'm like, here's one end where you like ejaculate too fast, and here's where you can't reach orgasm at all. So everyone lives on the spectrum. And so this SSRI is going to kind of help us line up somewhere in the middle. So if we go too far to one end, we can kind of push back to the other. So one connection I was making when you're describing that is like on one end, we have pelvic floor pain, a lot of anticipatory anxiety, all these issues. And then the other hand, we maybe have like no ability to orgasm, decreased libido, all those things. And we're trying to kind of find that sweet spot, like how we need to make drinking straws that last like longer than 20 seconds, but like shorter than 15,000 years.
Sweet spot material. Yep.
Yeah, exactly. It's just like that, but with like SSRIs and kind of managing their expectations around it. Because I think some people have this binary view where they're like, if I take the SSRI, I give up sexual function forever. I don't get the libido, even though I don't have the anxiety. It's like, well, we can kind of like augment and move the dial in between those two things. So that's like one thing that's been helpful to me is like adjusting those expectations from the beginning, not just saying, here's this med and here's some side effects it might have.
Right.
But saying this is a dial.
We have in a couple episodes, we're having a guest come on who's a couples and sex therapist to talk about couples work and a little bit about kind of sex therapy. I will say one of the books I recommend to people, especially female identifying folks, can have a lot of stories, like you were saying, of how layered it is to the meaning of sex, the meaning of orgasm, that if they're struggling with this, I'll try and like alter the med. We think about dosing differently and seeing if we can reduce or try like a different medication for like if they're struggling with depression versus anxiety. But also the book Come As You Are, which is I feel like a classic at this point. And it will be next to your book on my shelf of just helpful books. Just to kind of get at like, well, what do you mean? Like when you say, I don't feel as much desire for it anymore. Because I kind of think Preston, similar to you, like an SSRI might move your like desire amount on the spectrum or like your difficulty with orgasm to making it harder or less desire. But often when you have that longer conversation, it's like, well, what was desire like for you before? What was, sex like with your partner before? Who initiates, how all these things that are happening and when does desire come up? And often it's like someone's 6 months postpartum and they're tired. And so all of these things come up at the same time. And it's, very complex.
And the source of their motivation changes too. So like desire may not always just be like sex drive. For a lot of patients, it's like their desire comes from like a fear of disappointing their partner, which is also relieved by anxiety. So they're like, oh, now that I'm no longer like anxious about like constantly displeasing or disappointing my partner, like my sex drive has gone away. But that was like never really sex drive. It was just like...
It was sex obligation kind of.
Yeah. It was just like more anxiety.
Mm-hmm.
So then on top of that, like that may move the dial way too far. And then you have to rediscover like, oh, what if I had sex because I wanted to and I enjoyed it, not just because I saw this as like one of my duties in the relationship.
Mm-hmm. Mm-hmm. Yeah. Okay. Our last question, which is I don't think we're really going to get to address, but someone asked me perimenopause, must we? ? It's kicking my ass and I feel crazy was another person's.
Must we? Unfortunately, we must.
Apparently, unfortunately, we must. Do you see people in the like perimenopause, menopause period, or like I know prolapse can be kind of more common later on, but like yeah.
Absolutely. I mean, so estrogen is a really protective hormone.
Mm-hmm.
And so once we start experiencing that drop in estrogen, we start to lose muscle mass. We start to have all of these other, physical changes, including in the pelvic floor. And so people who, maybe have never had pelvic floor issues before, all of a sudden will start experiencing them, or people who maybe initially did right after they had a baby. And then like once things kind of rebounded to normal hormonal levels, they were like fine and they didn't do anything about it. And then when that estrogen drops, it's like, ooh, we've just kind of unmasked these problems that were lying in wait. Mm-hmm. So definitely like that is a big population that I work with.
Yeah. It's going to be another flux. Like I'm starting to see more wellness-ish content, which I like write about on Substack of like, let me read the research because it's not happening. Like, and I feel like there's a lot of perimenopause stuff that is coming up or I see people asking about. It's actually not being targeted towards me yet, so I'm not seeing it. I'm seeing like responses from other healthcare people on TikTok about perimenopause.
I was going to say, I'm like seeing like the GYNs fighting on Instagram and
the girls are fighting.
Yeah, the girlies are
fighting. And so I feel like there is this part of me that knows it's starting to get asked more in clinic. And I've actually had a couple patients ask me like, who are maybe like late 30s, like, I'm seeing all this stuff about perimenopause. Is that why I'm not feeling well? Like, should I be on X, Y, or Z, like hormonal questions? And in the psychiatric lens, there are some things we know, but unfortunately, there's still a lot that we're learning about how exactly we correlate hormonal changes with mood changes or mental health concerns. So that we know it's a correlation, but I don't think there's a clear direction. But online, it's like, if you just were a goddess with your hormones, then and you got my green supplement, then you wouldn't experience menopause.
Right.
Yeah. The difference between me and you is I eat healthy.
The difference between me and you is I'm better than you, and I'm more of in my feminine girl era.
Yeah, in your divine feminine energy or whatever. Yeah,
present in his #Hegel era, divine king.
I am. So as I approach perimenopausal age,
I just want to check you do know you don't go through it.
Okay. I am a doctor. I do know these things.
You didn't know you had a pelvic floor.
Yeah, I know.
He's going through menopause.
The poor anatomy allegations. So, but for this person who like has the problem lying in wait, I guess, how would you counsel them? Like if they had like pelvic floor problems during their pregnancy and now like they don't have any issues. They're in their mid to late 30s, but this big event is coming up. Are there like preventative approaches or like almost like prophylactic pelvic therapy that you can do?
I mean, here's the thing. You can certainly always come in and we can always do an assessment and we can say like, here's how your pelvic floor is functioning right now. And then we can also have, a good discussion about what your current exercise routines are. We can start to touch a little bit on nutrition and making sure that like the things that you're doing are setting yourself up to like have good muscle mass, have good mobility, have good, all of the things. So that, when you start to notice changes, you can say, okay, well, at least I'm controlling the things that I can control. And maybe there's something now happening that's outside of my control. And that's when you talk to a provider.
Gotcha.
I feel like the one thing I think about with people talking about perimenopause and menopause too is, Dr. Hilary McBride is a psychologist and she does a fair bit of work on eating disorders, but more than that, like embodiment stuff, and has some research on different ways people go through menopause, and that like though their physical sensations can be really unpleasant and it can feel like your body's totally changing, there are also people who experience those changes like wildly differently in terms of like feeling almost a second like freedom or that is an experience too. Because I think one of the things I fear with all the perimenopause discourse is just adding more things for women to be afraid of in their body, without actually creating more compassion or giving them more tools, but just being like, oh no, look at this. You're gonna go through this.
Another
and it's gonna be
valve
awful.
that can leak or break
Yeah.
in your car.
Yeah. Yeah. I do think there are other stories. I think we don't fully know them yet, but that can help people go through menopause and not feel like their life is over.
Right. No, exactly. It doesn't have to all be this really negative thing. Like there are certainly a lot of positives to associate with it. And I think staying mindful of the things that you need to pay attention to, but also looking at this as like, oh, this is cool. This is another, phase of my life where things are going to be different. And that might come with additional freedoms and, whatever.
Getting old is a privilege.
That's right.
Oh, those are all of our questions that we had gotten. I think one last question I have for you, given, nothing in particular, but just the current world, I wonder if there are clinicians or other people you follow online who you feel like are really good health communicators that you would want to shout out, or you feel whether they're pelvic floor or not, or pelvic floor or physical therapists, but where people might be like, oh, this is a place you can get information, similar to how there's a lot of misinformation about pelvic floor PT.
Totally. I think from a urogynecology standpoint, Jocelyn Fitzgerald is awesome. She talks a lot about, where she's kind of like the surgical version of me. So it's like, if we need to like take this to the next step, like here's kind of how it works in the urogyn world. She also does a lot about talking about, women in medicine and things like that. So, I really love her account. She's also just a really great person. Karen Tang is, a GYN. She's a minimally invasive gynecologic surgeon. So she does a lot of work with like endometriosis. She does some gender affirming care. She does really, really good educational videos. And yeah, those are probably my top two, but I mean, there's so many good creators in the women's healthcare space. And it's one of those things where I, was always kind of intimidated when I first got online. Like, oh, there's these like, people that are kind of household names to me. And like, who am I to think I'm going to make my own platform? But they're all so incredibly welcoming and caring, and just like the fact that they're lending their voices to the internet is really cool, and I think really speaks to their character.
I've always really enjoyed meeting like creative and aspiring individuals like in person, that you're describing. Like these are really like philosophers, educators, like charismatic speakers that are kind of like changing the tide of our time, and it's wonderful that we get such easy access to them through platforms like TikTok and Instagram.
Totally.
And you're among them. Those are your colleagues. So I know you've made a lot of like comments about how it's hard for you to imagine like you're an authority figure among them, but I want to say like I see you that way.
Thank you.
And if I had to do pelvic floor exercises, I would go to your page. Well, I mean, I do have to.
Sometimes
because I have
just
one,
start a sentence and I don't know how it's going to end. Your book is out now.
Yes.
I think it came out maybe 2 days ago. Yesterday,
like a couple of days ago, like Tuesday. Yeah.
So, people should get it. I think if anyone is working in women's health, especially, or men's health, but I think this is a great resource because honestly, so many of my perinatal patients, it's just like the myths comes up, or they're actively suffering, or they're going through IVF and all of these things. And I think it's going to continue to be important. And clearly you have 1 million people following you for this content. And that should say something to us as providers that this impacts a lot of people.
And so if I wanted to find you, it'd be at the Pelvic Dance Floor.
Yes.
Is that right? On Instagram and TikTok? Okay. And you have a website too, right? The pelvicdancefloor.com.
Yes.
And when will you be
did that
opening a
this year.
club?
Yeah.
Can we go to the club?
Okay.
Maybe I need to sponsor like the next like pelvic floor physical therapist get together at a bar, and we'll just call it the Pelvic Dance Floor. Yeah.
That'd be awesome, I think. Awesome.
Okay. Do you want to stick around for our outro?
Yeah.
Okay. This is where I have to go into like full podcasty mode. So thank you to Alicia. Thank you, Margaret, for listening, including me in your conversation. thank you to all of our listeners for doing what you do every time, which is listen. You guys are really good at it. And
your questions, they help us a lot.
They do. So also your comments help. How was the show? We always want to know what you think. Please leave your feedback. I do read it and I think about how to incorporate it. One thing that Margaret and I have been working a lot is not stepping on each other's toes, because some people think that I interrupt Margaret too much. Some people think Margaret interrupts me too much. And I think we realize we just both need to interrupt each other the same amount. So it's basically equitable. You can also contact the team directly at howtobepatientpod.com. You can see both content on my YouTube at It's Presro or Bad Art Every Day. Margaret talks about on her Substack as well. And we'll incorporate all of any resources we have into the show notes.
Thank you for everyone who's left us comments and reviews. Special shout out to the person who thinks we are both relatable and refreshing. I see Preston's not trying to Kegel anymore, who said, I'm a young attending physician in a different field subspecialty, but very much enjoy this podcast. It resonates both as a person and as a physician on many levels. Well done and thanks. I can't wait to see it and hear how it evolves. Wow, that sounds super clinical, but here we are. Thank you. And it really helps us a lot when you guys comment or leave reviews. And so if you want there to be a season 2, do us a favor by leaving a review, and then we'll sound legit so we can get guests like Alicia on and be like, this podcast is a real thing.
Welcome to season 2 of us yapping.
Dropped, yeah.
So, to wrap things up, we are your hosts, Preston Roche and Margaret Duncan. Our executive producers are also me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benz-V. To learn more about our program disclaimer and ethics policy, submission verification, licensing terms, and our HIPAA release terms, go to our website, howtobepatientpod.com, or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production. Thank you for listening, and see you all next week.
Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance.